critical care. It's a case of an 82-year-old female who was admitted from ED with a history of fever, shortness of breath for 4 days. Her GCS was E3, B4, and 4. Blood pressure 90 by 60 mmHg, heart rate 130 per minute. Her height was 165 centimeter, weight 47 kg. TLC was high, 21,000. Procal was 12. Her bilirubin was 2.2, SGOT 56, SGPT 60, albumin was low, that is 2.1, and globulin 2.2. Her urea was 42, slightly on the higher side. Creatinine was 1.4. She had hyponatremia, hypokalemia. Her chest X-ray showed a right lower zone opacity. Her urine microscopy was normal. So she lives alone at home, and her caretaker came along with her, who told that she had a history of weight loss in the past few months. When she came to us, we treated her with antibiotics, bronchodilators, and other supportive measures. Now, for managing nutrition for this patient, there are a few questions that need to be assessed. First, what is her nutritional status? Second, when should we start nutrition for this patient? What route of delivery should be used? Then what are the components that are needed to be provided and in what doses? Then how do I plan nutrition for her and how will I monitor my patient? So the first question that needs to be addressed is nutritional status of the patient. So this was discussed in great detail in the previous class. So I'll just give you a basic understanding. So there are different scores that help us assess the nutritional status of the patient. The two most commonly used scores are nutrition in critically ill, that is Nutrix score, and subjective global assessment, that is SGA. To assess for malnutrition, we can use ultrasonography. Bioimpedance analysis is the one that is the most accurate and most preferred. However, because it's not readily available, we rely mostly on Nutric or SGS. So for my patient, her Nutric score was 5, and her subjective global assessment showed that she was very high risk. Now, what route of nutrition should be given? So for all the patients who are admitted in the critical care unit, the best route of nutrition is oral nutrition. So whenever possible, we will prefer to continue oral nutrition. However, if there are any contraindications for the same, or if oral nutrition is not possible because patient is drowsy or is intubated, obviously, these are the conditions we will go for alternate routes of nutrition, where we have enteral nutrition as the most preferred route. If there are contraindications to enteral nutrition, this is the time when we will think about giving parenteral nutrition. Now, timing of nutrition. So if the patient, so every time we will prefer to start oral nutrition for patient unless it is not possible, like I told, drowsy patient. So in this case, we will just continue oral nutrition. If patient has to be started on enteral nutrition, then we prefer early enteral nutrition, that is within the first 48 hours of ICU stay. If enteral nutrition is contraindicated, then we will go for parenteral nutrition, and generally we prefer delayed parenteral nutrition. That is, we started from day 3 and then progressively increase it over the 3rd to 7th day. Now, according to the timing of nutrition, the early medical nutrition can be divided into early enteral nutrition and early parenteral nutrition. So wherever oral intake is not possible, early enteral nutrition within 48 hours is definitely preferred over delaying enteral nutrition, and it is also preferred over early parenteral nutrition. So what conditions where early enteral nutrition should be performed? It is given if patient is on ECMO, if patient has traumatic brain injury, if patient has ischemic or hemorrhagic stroke, any kind of spinal cord injury, if patient has severe acute pancreatitis, has undergone abdominal surgery or abdominal aortic surgery, if patient has an open abdomen, in patients with diarrhea. Now, early parenteral nutrition. Early parenteral nutrition is given if there are contraindications to enteral nutrition and if the patient is severely malnourished. Because otherwise, we will go for delayed nutrition, delayed parenteral nutrition. But if patient is severely malnourished, that is when we will give early parenteral nutrition if enteral nutrition is contraindicated. And in patients who are not able to tolerate full dose of enteral nutrition over a week, that is the case where we initiate parenteral nutrition. Now let's talk about delayed medical nutrition. Now, delayed medical nutrition, enteral nutrition may be delayed if patient has shock, which is uncontrolled, and hemodynamic and tissue perfusion goals are not reached. And whenever the patient's hemodynamic stability is maintained with the help of fluids, vasopressors, and inotropes, this is the condition where we can initiate low-dose enteral nutrition. Delayed, but we'll still try to control the shock with fluids and vasopressors and then start the patient on enteral nutrition. Then in case of life-threatening hypoxemia, uncontrolled hypercapnia, or acidosis, enteral nutrition may be delayed, and then it can again be started once the patient has stable hypoxemia and compensated or permissive hypercapnia and acidosis. Enteral nutrition may also be delayed in patients who are suffering from active upper GI bleed, and it can be started again once the bleeding has stopped and if there are no signs of bleeding. It may also be delayed in overt bowel ischemia, in high output intestinal fistula, in patients with abdominal compartment syndrome, and if the gastric residual volume is above 500 ml per 6 hours. Now, low-dose enteral nutrition, it should be administered in patients who are receiving therapeutic hypothermia. For example, after a CPR, when the patient is receiving therapeutic hypothermia, we need to initiate low-dose enteral nutrition. Then in patients with intra-abdominal hypertension, which has not yet gone into abdominal compartment syndrome, we can start low-dose enteral nutrition, but then it needs to be discontinued if the patient develops intra-abdominal hypertension. Low-dose enteral nutrition should also be administered to patients with acute liver failure when acute, immediate, life-threatening metabolic derangements are controlled. Coming to delayed parenteral nutrition, as I already said, whenever there are contraindications to enteral nutrition like shock, hemodynamic instability, and tissue perfusion goals are not met, these are conditions to start delayed enteral nutrition. But we need to remember that before starting parenteral nutrition, we have to try all the strategies to improve enteral nutrition. Only if it is not possible, then we will go for parenteral nutrition. Now, once for my patient, because she had shock, I'll try that she is started on oral nutrition. But if it is not possible in case she is drowsy, first I will try to maintain her hemodynamic instability and then start her on enteral nutrition as soon as possible. Now, how much calorie does she need? So to identify how much calorie the patient requires, we prefer doing indirect calorimetry. We calculate the resting energy expenditure using indirect calorimetry. Here we have to first measure the VCO2, which is obtained in intubated patients who are on ventilator. The ventilator will give us the VCO2, and then using it, we can calculate the resting energy expenditure. But this is the most preferred method. However, it is not always possible because such a measurement is not possible for every single patient. Not every patient is on a ventilator. So in that case, we can go for predictive waist weight calculation, where we multiply the body weight of the patient, multiply it with 20 to 25. It has less accuracy, only about 60%, but then this is the one that can be performed at bedside and is easier to perform. So whenever we need to give calories to a patient, so we will always, if we are going for the accurate method of calculation, that is indirect calorimetry, in this case, we can start with full dose enteral nutrition since day one because it's the accurate measurement. However, if we are going for alternate method, that is predictive weight-based calculation, in this case, we need to start with hypocaloric nutrition. That is, we will start with 70% nutrition of the total estimate of the calorie from day one, from the first 48 hours, that is, and then from day 3 to day 7 onwards, we can gradually increase the nutrition to 80 to 100%. We do not want to overfeed the patient because there are risks and complications of refeeding syndrome, which I will discuss later. This is the reason why we prefer hypocaloric nutrition in case we are using weight-based calculation. Now, protein requirement in critical illness is 1.3 gram per kg, and it is known that physical activity improves the beneficial effects of nutritional therapy. For my patient, since her weight is 42 kg, her calorie requirement becomes 1,125. And for target for day one, as I said, we have to give hypocaloric nutrition. So it is 70% of 1125, that is 800 kilocalories. calories. Now, how will I achieve this calorie requirement for my patient or for any other patient? We have to provide the patient with macronutrients, which can be in the form of carbohydrates, proteins, and lipids. So exact optimal carbohydrate amount is very difficult to determine because any critically ill patient has endogenous glucose production and at the same time also has insulin resistance. But we do know that glucose administration should never exceed 5 milligram per kg per minute. And the safe option is to give 150 gram per day, out of which 100 to 120 gram per day will be utilized by brain and the rest by RBCs, immune cells, renal medulla, and the transparent tissue of the eye. So for my patient, I can start with 100 gram of carbohydrate, which will provide about 400 kilocalorie out of the total 800 kilocalories that she requires. Then 1.3 gram per kg protein equivalents per day have to be delivered. So we can start from 1 gram per kg and then progressively increase and go up to 1.5 gram per kg protein equivalents. IV lipids, they should never exceed 1.5 gram per kg per day. So for my patient, she can be given about 20 to 22 gram of lipids, which will provide 200 kilocalories. So total 400 from carbohydrates, 200 from lipids, and the rest about 160 to 170 will come from proteins. So this will provide her with the calorie requirement that she has. So according to the ESPN guidelines, they also talk about micronutrients. They say that adequate amount of all essential trace elements and vitamins shall be supplied to all the patients receiving medical nutrition from the beginning of the period of nutritional support. So now I will highlight on the micronutrients that may be supplemented. So we have sodium, potassium, calcium, chloride, magnesium, and phosphorus. In my patient, she had hyponatremia and hypokalemia. So she can be provided 22 milliequivalents per kg of sodium via enteral route and 51 milliequivalents per kg of potassium via enteral route. These are the different doses of these nutrients via enteral and parenteral route. The other micronutrients that may have to be supplemented are chromium, copper, fluoride, iodine, iron, manganese, molybdenum, selenium, and zinc. Then the water-soluble vitamins, that is mostly vitamin B complex, they may need to be supplemented. And for fat-soluble vitamins, that is vitamin A, D, E, K, they may also have to be supplemented. Now, different micronutrients and how they are associated with various diseases. Alcoholism, as we know, it can result in thiamine deficiency and it can also result in zinc deficiency. Alcoholic hepatitis is something that can get worsened because of zinc deficiency and then can also result in further zinc deficiency. Cardiomyopathies can develop as a result of thiamine deficiency. COPD may get worsened because of vitamin D deficiency. Inflammatory bowel disease has chronic diarrhea, so then that can result in zinc deficiency. Then obesity is also similar to alcoholic hepatitis. It can get worsened because of zinc deficiency, can also result in zinc deficiency, and so on and so forth as given in the table. Now, different therapies can also result in various deficiencies, like renal replacement therapy can result in deficiency of water-soluble vitamins. Diuretics can cause thiamine deficiency. Proton pump inhibitors, because they inhibit the absorption of vitamin B12 as well as iron, can result in their deficiency. Metformin, as we all know, results in vitamin B12 deficiency, and isoniazid results in pyridoxine therapy. That is why anti-tubercular therapy, we have to give pyridoxine along with isoniazid. Now, different nutrition, we have different kind of protein powders and liquid nutritional therapies, and one such example is Ensure. So for my patient, if I want to give Ensure powder for enteral nutrition, one powder, that 100 gram of one powder provides 410 kilocal of energy. My patient, if you remember, requires 800 kilocalories. So 2 Ensure powders will be required for my patient, which will provide her with 800 kilocalories. They will provide her with about 118 gram of carbohydrate, about 23 gram of fat, and about 30 gram of protein, along with other micronutrients, that is minerals and vitamins. Now, how much volume needs to be given? Usually, we prepare each kilocalorie in 1 ml. So total volume for my patient will be 800 ml. Now this volume can be adjusted according to the fluid status of patient. In case the patient has fluid overload, then we can give them less amount of volume. So the volume that we are giving will be more concentrated with the calories for an over fluid status patient. Now different enteral formulations that can be given are kitchen-based feeds, ready-to-mix powder formulas, and ready-to-hand liquid formulas. Now, kitchen-based feeds, because obviously they're prepared in the kitchen, they are more likely to be contaminated as compared to the ready-to-hand liquid formulas. And the ready-to-mix powder formulas are also prepared within the ICU, so they also can get contaminated. Then the preparation time, kitchen-based feed and powder formulas take more preparation time as compared to the ready-to-hang liquid. The kitchen-based formulas, they can also clog the tubings, whereas this won't happen in case of a liquid formula. Then the consistent nutrition delivery can be obtained if we are giving the ready-to-hang liquid formulas and even ready-to-mix powder formulas, but not with kitchen-prepared feeds. That is why the most ideal is to give ready-to-hang liquid formulas, but the most commonly used is kitchen-prepared feeds. Now, what is volume-based feeding and what is rate-based feeding in a critically ill patient? So for any patient that is in the ICU, we need to fix a flow of nutrition and the timing of nutrition. For example, if for my patient I fix that she has to be given 50 ml per hour, that is the flow that needs to be given, and I fix the duration that for the first 16 hours of the day she can be fed, and in the next 8 hours in night she won't be fed. However, there can be times when nutrition may have to be stopped. For example, if patient is nil per oral before a procedure or before an ultrasound, in that case, we need to decide whether we want to compensate for the missed doses of nutrition or not. In rate-based feeding, we will not compensate for the missed doses of nutrition. And once the NPO timing is over, we will just continue with the feeding that we were already giving. However, in volume-based feeding, we always want to supplement the missed doses, either by increasing the flow. I can increase the flow from 50 to 100 or 150, etc. Or by increasing the duration, that instead of feeding for 16 hours, I decide to feed my patient for a more amount of time, that is 20 hours or 21 hours. So that is volume-based feeding. Studies suggest that volume-based feeding is preferred over rate-based feeding because the patient will have improved energy and protein provision. Now, when we have to give enteral nutrition, we need a gastric access, which can be obtained via nasogastric tube or nasojejunal tube or percutaneous endoscopic gastrostomy. Nasogastric tube is the most easily performed and it is non-invasive. However, it can be traumatic to the nose or the mouth. Whereas percutaneous endoscopic gastrostomy and nasojejunal tubing, they both are invasive, require endoscopy, complex, but there is no trauma to the nose or the oral cavity. The most commonly performed is nasogastric tube, and the preferred one is nasojejunal tube. Now coming to increasing the feeding, as I said that on the first day, in the first 48 hours, we give isocaloric nutrition. So I'll be giving my patient only 70% of the calorie requirement, so which I had calculated as 800 kilocalorie. However, her total calorie requirement was up to 1200 kilocalorie. So then I can gradually increase her calories over the next 3 to 4 days. Once medical nutrition has been started, the patient also needs to be monitored. I need to monitor her for tolerance, overfeeding, underfeeding, and at the same time for any complications of nutritional therapy. So how will I know that the patient is being adequately fed? It can be checked using glucose and insulin measurements. So blood glucose measurement has to be taken at least every 4 hours for the first 2 days in general when the patient is admitted to critical care unit. And whenever the glucose levels rise above 180, that is when we can start insulin therapy. Then we also have to check for feeding intolerance. If patient has feeding intolerance, intravenous erythromycin can be supplemented as first-line prokinetic agent. And alternatively, we can also supplement intravenous metoclopramide or a combination of the two. Then patient also needs to be monitored for any refeeding complications, for which I have to check the electrolytes, that is potassium, magnesium, phosphorus, and if any of the following they decline, then replacement therapy may be given. ECG monitoring also has to be done for the patient, because with hypokalemia, the patient might develop cardiac arrhythmias. Now, how do I measure the gastric residual volume for my patient? There is a wide variation in practice. Some centers use a gastric residual volume threshold as low as 150 milliliter. High gastric residual volumes may occur after vomiting. And if the gastric residual volume is very high, there is a risk of developing aspiration pneumonia. That is why it is important for all critically ill patients to undergo gastric residual volume measurement. Now, how do we approach gastric residual volume? It needs to be checked every 6 to 8 hourly. In case the gastric residual volume becomes more than 500 ml, then we have to replace all of the aspirate up to 500 ml, discard the rest, and flush with 10 ml of water. We don't need to stop the feed or reduce the feed. We will just commence erythromycin prokinetic agent or metoclopramide, and then continue with the enteral nutrition at the target rate and continue monitoring every 6 hours. If the second reading is also more than 500 ml, then we will replace all of the aspirate up to 500 ml and discard the rest. This time we will have to reduce the enteral nutrition. So we will halve the enteral nutrition delivery rate for 6 hours. And then again, we will continue monitoring the patient every 6 hours. In any case, after 6 hours, if the gastric residual volume becomes less than 500 ml, then we can increase the enteral nutrition back to the target rate that we had set before. If the third reading also comes to be more than 500 ml, then we will have to cease all enteral nutrition via gastric delivery. We will consider nasojejunal tube placement, and we will also at this point of time consider supplementing parenteral nutrition. What are the complications of enteral feeding? There can be occlusion of the feeding tube, reflux of gastric contents into airways, which can result in aspiration pneumonia, as I discussed. There can be diarrhea, bloating, and abdominal discomfort. Now, it is important to document nutritional therapy. So documentation of body weight and its review on weekly basis is recommended. And we can also screen the patient. We can use assessment tools and score. We can have a nutritional diagnosis, a care plan, and also check the patient for any infectious complications and stool frequency to assess that the patient does not develop the side effect of diabetes. Thank you.
Thank you, Dr. Astha. It was really nice presentation, and I think you covered thoroughly how to assess till how it is delivered and what composition should be delivered and what time should be delivered. So my key points after your presentation is nutritional assessment starts since patient gets admitted in ICU or anywhere else. Nutrition assessment should start right at that moment of time, and it should be continued on daily basis, whether we are overfeeding the patient or we are underfeeding the patient. And yes, the route, the dose, composition, and how patient is going to is tolerating that is also very important. So thank you for this nice presentation.
We can go to the other panelists. Dr. Chandramani Punjabi is there. And if anyone has any queries, they can just type in a chat box. Then you can take these queries. Yes, Dr. Chandramani. Can you turn your video, please? Hello, Dr. Chandramani. Yeah, I think Pratibha is also here. Pratibha Dixit. He is a dietitian in Artemis Hospital. You can make her comment. Any comment? Yes, Pratibha. Pratibha, please unmute yourself. Yeah.
Hi, good evening, everyone. Dr. Astha, it was a very nice presentation, first of all. And yeah, day-to-day basis, we many challenges we have while we deal with the nutrition of the patient. It's not very easy. Yeah, nutrition is important as the medicine is. But I have one thing to ask you. There are many patients, we are not able to start nutrition at day 1. Okay,
Yes.
and for day 2 and for day 3. So there will be a cumulative calorie deficit. So do you have any suggestion that how can we overcome that?
Actually, yeah. Actually, there will be some calorie deficit when patient is very critically ill. Patient may be in septic shock and all. So initially, when the ESPN guidelines, they don't suggest to go full dose in initial days, because even if you give feeding, the body is not ready to accept it. So we can start as low as 500 kilocalorie per day. It is called trophic dose. But later on, and we're also doing a study, Pratibha is aware of that we study, and we try to see the calorie deficit in critically ill patient in first 1 week. So when patient is patient is recovered from shock and the criticalness is less, then we can try to compensate for this calorie in later days, like on day 3, on day 4. Initially, the nutrition usually take the back seat, and the hemodynamic optimization, infection control, they take the front seat.
Yes.
Astha, do you agree with that? You unmute this. Yeah.
Yes, I agree with what you said. In the initial few days, the patient, anyways, we have to give hypocaloric nutrition and can be compensated.
Because it is already said, there is a point in ESPN guidelines that some nutrition is always better than no nutrition.
Yes. It is not that only for calorie requirement. If you use the gut, it is also help to prevent transmission of bacteria, and it also reduce the chance of infections.
Right.
Dr. Chandramani, please. Your comment,
So
please.
am I audible?
Yeah, you're audible.
Okay, so I think that was a very wonderful presentation by Dr. Astha about the enteral nutrition in the critically ill, and she has very beautifully highlighted how to start the nutrition and how to avoid the refeeding syndrome. So I think just to summarize for the audience, we can divide the critically ill nutrition into 3 phases. First will be the acute phase, which is divided into 2, the acute early phase, which is the first 24 to 48 hours when the patient comes to the ICU, where we have to assess the nutritional status of the patient, see the underlying pathology with which the patient has been admitted, and then we give the nutrition. And during this acute early phase, we mainly consider the enteral nutrition if it is possible, and try and give the energy target of 70% of the daily calorie requirement. And the protein should be on the higher side, around 1.25 to 1.5 grams per day. Then is the acute late phase, where we add on parenteral nutrition if it is needed, that is from day 3 to day 7, and we increase our energy target from 70% to we can go up to 100%, and the protein target also is met, so that the malnutrition is covered up. And then we move on to the recovery phase if the patient stays in ICU more than 7 days, where again we try and disconnect the parenteral nutrition, continue with the enteral nutrition, and give our 90 to 100% of the energy targets.
Okay.
And also refeeding syndrome, that has to be avoided, especially in the first few days, especially if the patient has not taken any food for the last few days at home prior to coming to the hospital. So we do not have to be very, very aggressive and look at the electrolyte abnormalities. Magnesium is very important in such patients. We usually focus on sodium, but calcium, magnesium is important. Some patients we have to look for trace elements, and we have to give trace elements like salicylate solution has to be given.
Correct.
So I think again, very nice presentation by Dr. Astha.
Mandusa has a question. I think he.
Yes, sir.
he
Can
or
I
she.
speak, sir?
Yeah. Please. Yes, please.
Sir, first, my question is,
Please
as
turn
per
on your
my
video.
knowledge,
Yeah.
I'm at home, sir. I'm with
Yeah.
kids.
Okay. No
Actually.
problem. Okay.
Sir, as per my knowledge, I think it is not like first day we have to give 70% nutrition, right? We need to reach at least 70% nutrition. Is that correct?
Yeah. 70%
So
nutrition
basically,
if we use this formula.
It is not like we should give 70% nutrition. The target, or we should at least minimum we should give
Yeah,
70%
No,
nutrition,
no,
right?
no. Actually, this is coming from the ESPN guidelines.
Yes.
You should not try to give full dose in the first day or day 1 or day 2. It's the ESPN guidelines,
Yeah. So the maximum should be 70%. We can give 50
not that
also.
minimum
Say for
70.
example, yeah. So maximum should be 70%.
But
So
if you
maximum 70%.
if you use
Yeah.
indirect calorie, then you can go, because that will exactly determine how much calorie you need to be given.
If the patient is okay, if there is no refeeding syndrome, then
And, this is the guideline is for critically ill patient. The patient may be in the shop, maybe like you cannot give enteral full dose. If you give enteral full dose, there may be guard ischemia, and all these concerns are there. And this was studied, and they say both under and over nutrition, they are harmful to the patient.
okay, sir. Sir, my second question is,
Yes.
we need to check electrolytes
Yes.
if the patient had a refeeding syndrome, right?
Correct.
That we should do once in a day, or is there any timing, like 6 hours frequency we have to do? Is there any timing, or once in a day is enough?
Any panelist can take the question. Shalini, Dr. Chandramani.
See, if we
Yeah,
get
so-
yes, sir. Yes.
So once in a day, every morning on the rounds, we must have the electrolytes with us so that we can plan the nutrition for that day of the patient. So nutrition will not only mean just the protein and the carbohydrates. So for example, if the patient has got a low potassium and we need to correct via the intravenous route and not via the oral route, so then we need to correct that. So on every morning round, we should have what was the calorie consumption of the previous day? Was there any problem in the feeding of the patient? Did the patient have any aspiration coming out from the nasogastric or nasojejunal feed? And what is today's nutritional requirement? Whether we want to give 70%, 50%, 80%, or 100% of the total calorie requirement. How much proteins we want to give, our dietitians take the round, they will calculate the total protein. Now regarding electrolytes, once a day is sufficient. But say for example, if the potassium today was 2.7, I have done the correction over 5 hours intravenously, then I would like to recheck the potassium after 8 hours. That's what it is.
Okay,
So
sir.
any
And
electrolyte which is abnormal, we can always recheck in the evening, but once a day at least, the major electrolytes we should be doing.
okay, sir. But I'm not sure. I think it is ASPN or ESPN. They said that 6 hours or 4 hours. I forgot actually. If the patient had a refeeding syndrome, every 6 hours we need to check. I forgot actually the guidelines. And
Yeah.
okay, sir, let it be. I'll check it later.
Yeah, so in
Sir,
refeeding syndrome, magnesium will be very important. Checking the
Okay.
magnesium levels and the phosphorus levels will be very important in refeeding syndrome.
Okay, sir. And my third question is, how much weight loss we can consider as a risk of malnourishment? Like, for example, patient weight loss is 10 kgs in 6 months, or 10 kgs in 6 months. So
I
which
think
one is
it was in percentage.
Yeah,
Like
so
not the absolute number, but it's a percentage. Like I'm not exactly sure, but I think 10%
10 to
of weight loss.
15%.
10% weight loss
yeah.
over 6
6
weeks is
months.
considered significant. 6 months is considered significant.
pardon, ma'am? Pardon?
10% weight loss over 6 months.
Okay.
So whatever the weight of the patient is, 10% of that over 6 months is significant.
Okay. Thank you
And
very
for your
much, ma'am. Thank
first
you.
question, your previous question, that 6 hours you were saying. So generally we will do every day electrolytes, but if patient
Yes,
has
ma'am.
refeeding syndrome, that is the condition when we check it 8 hourly or 6 hourly.
Yes, ma'am. Yes, ma'am. Thank you very much, ma'am. Thank you, ma'am.
Thank you for your questions. Any more question? Or any comment from panelist or the speaker or from the speaker? So
I think Induja had a question: in how many days do we see the effect of NG feed on patients?
What is the question?
How many
How
days?
many?
How many days do we see the effect of nasogastric feeding in patients?
Effect of feed on patients.
Effect, what effect? What, actually, I didn't get the question properly. Like, what
Effect
effect,
of the feeding.
like, what effect do you want to see? Like, we can see the assimilation of food, the calorie and the proteins we give. We can check the urinary nitrogen for that. And actually, the therapy is not that we give to see the effect, like there will be weight gain or something like that, but we have to give to prevent catabolism and to prevent the breakdown of the smooth muscles. And we can do also ultrasound, serial ultrasound to do that. And also we can do bioimpedance to do that. Do you like Dr. Chandramani, any comment for this?
One point I wanted to highlight, this point has come up in many of the previous conferences and workshops also,
Yeah.
that when a patient has diarrhea,
Yeah.
whether we should stop the feeding or not.
Yeah.
And all the guidelines say that we should not stop the feeding.
Correct.
And we must assess the cause of diarrhea. We must rule out C. difficile infection or any drug-induced or antibiotic-induced diarrhea. And therein, we can, check the electrolytes 6 to 8 hours and replenish them. One thing I wanted to ask the speaker and other panelists is that in patients having diarrhea on enteral nutrition, how frequently or whether are we using probiotics in these patients or not? Or what the guidelines comment?
Shalini, you want to take role of probiotic?
Probiotics
In
along
diet-
with nutrition in patients having diarrhea.
So we are in diarrhea patients, yes, sir, we are using it. If you ask about significant effect on outcome or the tolerance of the feed, that we are not able to say it clearly. But yes, they're used. Definitely, we're doing it.
Probiotic, the role of probiotic is particular in antibiotic-induced diarrhea.
Exactly.
We can use it provided the patient is not immunocompromised. In immunocompromised, we have some sort of hesitation using probiotic in those patients. Yes.
Okay, thank you.
So any comment, any query?
Okay, Dr. Astha, I would just want to know what practice you people are doing. Are you giving that 4 to 6 hour break to the patient in night, or are we doing it continuously on the basis continuously?
Ma'am, we are not giving continuous feed, but I know that the guideline, ESPM guideline recommends that continuous is better than bolus, but that is not what we are following in our practice.
So we are trying to achieve all the calorie protein requirement in a day on that 16 to 18 hour basis.
Hours,
Right?
yes.
Okay. So if there is no query or no comment, we can wrap up the session. Thank you, Dr. Astha, for this nice talk. And thank you, panelists, for joining and sparing your time. Thank you so much.
Thank you, sir.
Take care.
Thank you. Bye-bye. Have a nice weekend.
Thank you.
Thank you.